Welcome to the 50th anniversary of the American Journal of Sports Medicine. My name is John Dickens, and today I'm with Dr. Don Fithian, who is co-author of the 1994 top-cited article, Fate of the ACL Injured Patient, a Prospective Outcome Study. Dr. Fithian, thank you for being with us today.
Thank you, John. It's a pleasure to be here.
Great. Well, we'll jump right into it. Dr. Fithian, could you tell us what prompted you to do this study in 1994?
Well, I have to give credit, of course, to Dale Daniel and Mary Lou Stone in particular. Dale realized during the late 70s and 80s, as many other sports surgeons did, that ACL injuries were difficult to diagnose. He was fortunate to work in a closed setting with an HMO, so we were able to create a clinic for diagnosing patients with acute knee injuries by having them examined by experts. So Dale set that up as a way to identify ACL injuries before they had had an opportunity to have a second injury. And the reasoning for the study was twofold. Number one, as I mentioned already, that it's difficult to diagnose these injuries unless patients are examined by an expert. And that also makes it difficult to understand the natural history because many patients don't present until subsequent injuries, which usually we know now represent meniscus tears.
Great. And what do you think makes this so impactful now?
Well, then as now, it remains one of the very few studies on ACL injuries that approaches a natural history study. It was not a natural history study because we were treating these patients, but to the extent that it helped us to understand how the knee will behave after an ACL injury, it remains very influential for me as well as for other practitioners and other researchers.
It's been almost 30 years since the article was published. What's your perspective on this paper now?
The paper continues to inform my practice and my understanding of published literature in that patients who are identified within a few weeks of the first knee injury have what could be described as an isolated ACL tear. Their natural history, the subsequent symptoms and problems in the knee, are going to be different than patients who present some months after their initial knee injury, because the patients that present late after ACL injuries tend to have meniscus tears. As many as 90% of them have meniscus injuries, and those become overwhelming. It's interesting that although the ACL injury has the more profound effect on subsequent knee health, meniscus tears are far more symptomatic and limiting. A meniscus tear will bother you just walking across a room, but an ACL deficiency won't bother you unless you're running and jumping or pivoting. So patients perceive the meniscus tear as being the more disabling injury. We recognize the opposite. So for me, patients that present initially after an ACL tear, and I'm sure they've had no prior history, I can tell them that their next event won't be catastrophic. If they're a 40-year-old jogger or tennis player, they may be able to test the knee out. Their first re-injury will not be a catastrophic blowout of their knee. But if they have any symptoms at all of instability, then they either have to give that activity up or they should have the ACL reconstructed. And that's how it affects my treatment of patients. On the other hand, if the patient presents 6 months out and they have symptoms of instability, I can't use this article to guide my treatment because that's not they've already demonstrated that they have a symptomatic ACL deficient knee and they probably have a meniscus tear.
That's great. Well, thank you very much, and congratulations on your top-cited 1994 article in the American Journal of Sports Medicine. It's been a pleasure.
Thank you, John. The pleasure is mine.